Good morning, one and all, and congratulations to all of those students who have done well during their INI-CET exam, which was done yesterday. So this is an step taken by ADrPlexus to do a quick recap and recall of the questions in the medicine. And there is a question regarding stages. This question asks you to match the stages and also the symptoms corresponding to the stages. So what is iron toxicity? Iron toxicity usually occurs when children inadvertently or an adult by suicide attempts take iron tablets that is usually prescribed for iron deficiency anemia, as all of you know, or in a prenatal woman. So when this iron tablet is taken in, this iron tablet, when it goes into the GI system, this will act as a corrosive. This is one manifestation of iron. The other manifestation of iron include cellular toxicity, because it goes and gets concentrated within the mitochondria, thereby affecting the cellular respiration. The manifestation of iron toxicity is described in stages. In fact, there are 1 to 5 stages of iron toxicity that has been described. And usually, ingestion of 20 to 60 milligram per kilogram of iron is enough to cause toxicity. And if it is more than 60 milligram per kg, it causes severe iron toxicity. In fact, so what are the stages of iron toxicity? Once we see the stages, it will be easy to answer this question. This is a straightforward question. Stage 1. What is stage 1? Stage 1 is usually occurs less than 6 hours after intake. Stage 1 usually occurs less than 6 hours after intake. And this stage 1 will present with GI symptoms. They will present with GI symptoms. What do I mean by GI symptoms? I told you it act like corrosives. So in the GI symptom, it can cause mild symptoms or major symptoms like hematemesis or hematochezia. So it can be as simple as a simple abdominal pain or vomiting or diarrhea. That is mucosal damage. Mucosal damage. Apart from that, there can be blood, vomiting, and blood in the stools. So these are the possible GI symptoms when it is in stage 1, that is less than 6 hours duration. If a patient is asymptomatic within this period, that is asymptomatic when we are expecting symptoms, then these patients might have taken less number of tablets, or the number of tablets or the dosage should be questioned. If the patient becomes symptomatic, then the ideal time to do the serum iron levels is this time. Serum iron levels is this time. This is stage 1. Immediately after the mucosal damage have occurred, the next stage is stage 2, obviously. And what does stage 2 tells you? Stage 2 usually occurs within 1 day. This is within 6 hours, and this is within 1 day, that is within 24 hours. To be exact, 6 hours to 24 hours. This is the time period for stage 2, in which these GI symptoms will disappear. So what will the patient think? The patient will think that he is healing or recovering. So this period is known as period of apparent recovery. Period of apparent recovery. I hope you all get this, because this acts like corrosives. This goes and immediately damages the system. Before it affects the cellular respiration, it takes some time. This latent time is the stage 2, where the patient will think he is recovering, and this is a period of apparent recovery. Coming on to stage 3. What is stage 3? Stage 3 is within 72 hours. Stage 3 is within 72 hours, or for ease of remembrance, it is within 3 days. Stage 3 is within 3 days. Here, the patient may have recurrence of symptoms that occurred in stage 1, or there can be shock, organ damage. Organ damage, I mean kidney damage, liver damage, heart damage, etc. All organ damage can occur. That even coagulopathy is possible. Coagulopathy is possible. This is stage 3, occurs within less than 3 days duration or within 72 hours duration. Now, what is stage 4? Stage 4 tells you that it can occur within 96 hours. So within 4 days. Stage 4 occurs within 4 days, where the patient will have hepatic failure. Hepatic failure. And increased AST levels, ALT levels, and so on. But when you look closely, here also we have seen about organ damage, and this is also a manifestation of organ damage. But stage 4 is predominantly to deal with hepatic failure. Next comes the final stage, which is stage 5, which means there is GI scarring. Why should there be scarring? Because any corrosive injury, when given adequate time, say around a week's time, it will go in for healing, and this healing will cause scarring. This scarring within a luminal organ will cause obstruction. There can be obstruction, not always, but there can be obstruction, there can be malabsorptive symptoms, and so on. These are the 5 stages of iron toxicity. Coming back to the question, now please read the question yourselves. There are stages on one side and manifestations on the other side. Stage 1 is the stage of GI symptoms. Stage 2 is apparent recovery, and stage 3 is organ failure, and stage 4 is in fact an extension of that, which is hepatic failure. Stage 5 is not given. When we see the symptoms, please see here, it is pyloric stenosis. Stenosis means narrowing. It can be because of fibrosis. So that is one possibility, which we have studied as stage 5. Next is the symptom-free phase, which can be regarded as stage 2. Hemorrhagic gastroenteritis, though it can occur in any stages, it can occur in the first stage or in the third stage, because there can be recurrence of symptoms in stage 3, but we will wait. Then hypoglycemia-induced liver failure is also a possibility. This is regarded as stage 4, or that can be regarded as stage 3, because this is also an organ involvement. So we have now stages, symptoms for stages 2, 3, or 4, and 5. Here are stages 1, 2, 3, and 4. So how can this be arranged? Pyloric stenosis is stage 5. We'll wait for that. Stage 2 is symptom-free phase. Stage 3 can be hypoglycemia-induced liver failure or hemorrhagic gastroenteritis. But for stage 1, we do not have a theme. So we'll regard the gastritis to be the initial manifestation. We'll not consider that to be the recurrence. So we have now answer for stage 1 and stage 2. There is stage 5, but there is no stage 5 here in the question side. Now the hypoglycemia-induced liver failure could be regarded to stage 3. Yes. So you have the answer now. So stage 1 is hemorrhagic gastroenteritis. Next is symptom-free phase is stage 2. And stage 3 is hypoglycemia-induced liver failure, and stage 4 is pyloric stenosis. So there are few questions as multiple choice questions where there can be more than one answer positive, just like PGI type, the old PGI type. So here is a question regarding the enzymology and the disease manifestation, and they asked which among the following is true. So as you all know, so the cells contains enzymes. The enzymes is nothing but proteins or amino acids, and they have specific function and specific location too. This property is used to diagnose various conditions. For example, as we all know, in acute pancreatitis, the enzymology tests that can be done include serum amylase and serum lipase. Amylase can be from any source, but usually the increase in serum lipase is because of pancreatitis. So if at all you find serum amylase increase due to any reason, for example, DKA, pancreatitis, serum lipase measurements will tell you what is the source of serum amylase. So specific is serum lipase to pancreatitis. This most often people know. Now, coming on to Wilson's disease, this is a point regarding Wilson's disease, where ceruloplasmin is there, and the ceruloplasmin can tell you whether the patient is going in for hepatolenticular degeneration. This is to do with copper metabolism. This is to do with copper metabolism, where the ceruloplasmin can tell you whether the patient is going in for hepatolenticular degeneration. Nothing. Initially, to diagnose MI, various cardiac biomarkers were used. These biomarkers include troponin, which was non-specific, troponin T and troponin I, and it can be as simple as myoglobin, which is released. In fact, it is the first marker to come out of the cell, and this is positive even before troponin is positive. Next is CKMB, and the last one is LDH. This is what is taught previously. But now the current consensus is that highly sensitive cardiac troponin should be tested to diagnose MI. But irrespective of that, in most of the centers, these troponins are used. Now, this question is regarding LDH and MI. When we are talking about LDH, there are many isoforms. In fact, there are 5 isoforms of LDH. Each isoform is made of 4 subunits, and there are only 2 types of subunits. For example, there are types of subunits like H, which is predominantly seen in heart, cardiac muscle. These are intracellular enzymes. Or this can be M type, which is seen in muscles. So the 2 subunits are H and the second subunit is M. Either there can be 4H or 4M or any number of H or any number of M. Totally 4 subunits unite to form single isoform. So now there are 5 isoforms which are LDH 1, 2, 3, 4 and 5. The isoform 1 is containing 4 H subunits, and this is seen in heart as the name says. 2 contains 3 H subunit and 1 M subunit, and this is present in RBCs, and this is present in RBCs and also in the reticuloendothelial system. How to remember? I remembered it as 3H will be seen in 3 letters cells. 4H, 4-chambered heart. Now, what is isoform 3? Isoform 3 contains, as you all can guess, 2H and 2M, and this is seen in lung tissue. This is seen in lung tissue. Isoform 4 contains 1H and 3M. You are decreasing subsequently 1H every time. And this is seen in kidney. This is seen in kidneys. And isoform 5 contains only 4M and no H. Then this is seen in skeletal muscle. This is seen in liver. So these are the isoforms of LDH. This LDH can be used to know whether there is MI. So it is a marker for MI. It is marker for cancerous conditions. It is even a marker for prognosis of HIV infections. There are many applications for LDH. Today's question deals with MI. Normally, when LDH2 is more than LDH1. Where is LDH1? LDH1 is present in heart. LDH2 is present in numerous RBCs and reticuloendothelial system. Almost all other organs like liver, spleen, and all of the reticuloendothelial system. So obviously 2 is going to be greater than LDH1. And when MI or a necrosis have happened, now this gets flipped and LDH1 will be more than LDH2, and this LDH1 to LDH ratio will be more than 1. This is known as flipped LDH1 and 2 pattern. Flipped LDH pattern simply. This increase in LDH1 usually will persist for about 10 days. Usually this will persist for about 10 days after myocardial infarction, and this will increase by 12 hours duration. This is the last one. This is the first one. This is the second one to appear after MI. This is the third one. And LDH is the last biomarker, last measured biomarker to rise after MI. So this will rise after 12 hours and will usually peak from 24 to 48 hours. 24 to 48 hours. So now when we come back to the question, this is right because LDH1 and LDH2 ratio is going to tell you whether MI is present or not. Second one, serum lipase tells you whether pancreatic can be pancreatitis. Ceruloplasmin can be a marker for Wilson's disease. And last one, von Gierke's disease. Von Gierke's disease is a glycogen storage disorder, which is because of defect in an enzyme that metabolizes glycogen. So it is glucose 6-phosphatase or glucose 6-phosphate translocase. These are the enzymes that are defective in von Gierke, and it is not beta glucocerebrosidase. Therefore, since it is a multiple choice answer, 1, 2, and 3 are the possible answers if this is the right. Now, this is a good question, in fact. So, initially, multiple sclerosis was thought to be a demyelinating disorder of the central nervous system, which also affects optic nerve, which is part of the central nervous system. The cranial nerves, apart from cranial nerve 1 and 2, are parts of the peripheral nervous system. Cranial nerve 1 and 2 are parts of the central nervous system. So, multiple sclerosis is one cause of demyelination of the central nervous system involving brain. It can involve spinal cord. It can also involve the optic nerve. Later, and similar spectrum of disorder was found, which is little different from multiple sclerosis because the pathophysiology itself is different, the treatment should be different, right? And this was named neuromyelitis optica. Neuromyelitis optica. And as the pathology of the disease is more evident by researchers, there are more diseases to this spectrum, and this is together called NMO spectrum disorder. NMO spectrum disorder. So what is the pathophysiology here? The pathophysiology is antibody against aquaporin 4 channels. Aquaporin 4 channels are affected by antibodies. This is the basic pathophysiology. This aquaporin 4 channels is present in multiple areas, and these regions can be affected. And few of these symptoms will be the main presenting feature, and therefore they are known as core clinical symptom or core clinical criteria for diagnosis of NMOSD. So this is a question regarding the core clinical criteria. So these are the core clinical characteristics arising out of location of aquaporin 4 channels. Arising because of location of aquaporin 4 channels. Though this aquaporin 4 channels is present also in the periphery, you may see here these are all related to the central nervous system. Because the antibody mediated aquaporin 4 attack and the subsequent immune mediated damage to the cells is prevented in the periphery by specialized inhibitors, which is absent in the brain tissue. Therefore, the core clinical characteristics has to deal mostly with the central nervous system than the other regions. As the name says, it has to involve optic now. So there is optic neuritis as the first core clinical characteristics. Spinal cord is also involved, which is just one cause of transverse myelitis. So acute myelitis is also possible, which is a core clinical characteristic. Then area postrema syndrome. Area postrema is the area where vomiting center are located in the brain. And as we studied, this is outside the blood-brain barrier. So the antibodies can easily go and attack these regions, and the patient presents with vomiting syndromes. And this is area postrema syndrome. Brainstem, which is part of again central nervous system, is affected. The diencephalon, the thalamus and the associated structures can be affected. And the patient can have any of the typical brain lesions that go well with NMOSD disorder. These are the core clinical characteristics. If you have any of them, you try to rule out a demyelination of the central nervous system. If other symptoms are present, other symptoms may occur, other symptoms are present, those are not considered core clinical characteristics of NMOSD. Now coming back to the question, see the question, it's regarding core clinical criteria for NMOSD. So what are the things we have seen? Optic neuritis is the first core clinical criteria we have seen. Myelitis, it is not given here. So area postrema is the third one we have seen. Acute diencephalic syndrome is also possible. And since this is multiple type answer question, 2, 3 and 4 are possible, and focal epilepsy is not possible because focal epilepsy may occur, but it is not a core clinical feature. I hope everyone can get this. Coming on to the next question, it's regarding inhaled nitric oxide. This has been asked multiple times in various entrance exam, and this inhaled nitric oxide, either it is inhaled or endogenous nitric oxide. Nitric oxide is a vasodilator. Nitric oxide is a vasodilator. This nitric oxide will stimulate cyclic GMP production by stimulating guanyl cyclase. How does it cause a vasodilation? This stimulates guanyl cyclase, therefore increasing cyclic GMP levels. Therefore, it causes vasodilation. Where will the vasodilation be helpful? The question itself says inhaled nitric oxide. So even if you do not know the concept, This can be attributed to the pulmonary system because this can act locally. Nitric oxide has short period of activity. Therefore, when you inhale this, this is most likely to act at the pulmonary level than at the other levels. We do not use inhalational therapies for resistant migraine. We may use anticonvulsant drugs here if it is resistance to triptans on the other painkillers. And inhaled nitric oxide is not a therapy for resistant migraine. And from the options that we have now, it is the pulmonary artery hypertension which can be treated, or its response to nitric oxide can be studied by inhaled nitric oxide. We would really appreciate if we have contributions from your side regarding the correct questions on the other two answers. I hope this is understood by everyone. And going on to the next question. Yes. So there are many questions regarding COVID, and exam to the primary institutes want students to be up to date, and this is an example of that. So if at all a relative or a friend who has got recovered from COVID has to undergo an elective surgery, emergency surgery, there is no consensus on emergency surgery because it is an emergency. And for elective surgeries, when should they be taken up for surgery? So there is the American Society of Anesthesiologists has given some guidelines regarding that. So there is no major explanation to this. There is no major concept in this. So we are going straight to the answer. If at all the patient is asymptomatic but infected and he has recovered from a mild disease, a 4-week window before an elective surgery is ideal. If the patient is again asymptomatic and who do not require any hospitalization but have some symptoms like cough, dyspnea, etc., then a window period of 6 weeks is given. A period of around 10 weeks is given if it is a symptomatic patient and who has comorbidities. And 12 weeks for a patient who has recovered, who is admitted in the ICU. So that is 3-month period at the time of vaccination, post-COVID. Who is admitted to ICU, the time of vaccination only these patients can be taken up for elective surgeries. So, an elective surgery for COVID recovery who did not require hospitalization. They have not mentioned whether the patient is asymptomatic or the patient is symptomatic, but we will get that the patient who do not require hospitalization, we will take it in this way and we will try to get the answer. So 4 weeks for an asymptomatic patient who has only very mild disease or non-respiratory symptoms at all. So therefore, we will consider this 4 weeks to be the period of elective surgery after recovery from COVID. Going on to the next question. This is in fact a good question. So the patient has come to you with history of right lower limb weakness followed by the left lower limb weakness. So the patient is having one lower limb weakness followed by the other lower limb weakness with spasticity and a brisk reflex. So bilateral lower limb weakness, one followed by the other with spasticity and with brisk reflex. This is followed by wasting in the upper limb. The two options that are available for us now are the tropical spastic paraplegia or quadriplegia and amyotropic lateral sclerosis. This tropical spastic paraplegia or quadriplegia usually occur in tropical region, therefore the name. And usually this is HTLV1 associated. This will come and affect the neurons and this will cause symptoms mostly in the lower limbs. So this HTLV1 infection, not all patients with HTLV1 will develop TSP or HAM. HAM is nothing but HTLV associated myelitis or myelopathy. This is HAM or the other name of TSP. So HAM or TSP because of HTLV1 affects the neurons in the spinal cord. Because the neurons in the spinal cord are affected, the lower limbs are affected, one followed by the other, and there is spasticity in them. And because of the increased tone, there can be exaggerated reflex. This is all fine. But usually the upper limb is not involved in TSP or HAM. Usually the upper limb is not involved. And if at all the upper limb has to be involved, it should be no different from the lower limb involvement because the pathology is going to be same. There is no description of upper limb wasting occurring in TSP or HAM to the best of my knowledge. So if this question is right, if there is wasting of the upper limb and not weakness, then I will like to go more towards amyotrophic lateral sclerosis, which will have involvement of any motor system without sensory involvement. Here there is no description of sensory involvement or a definitive spinal level. So these push me away from TSP or HAM, and this can be a possible ALS where the patient will have both upper motor neuron lesion and lower motor neuron lesion. What do we mean by upper and lower motor neuron lesion? As you all know, this increased weakness, increased reflex and tone will tell you that this is an upper motor type of lesion in the lower limb where the lower motor neuron and the spinal reflex arc is intact. Whereas the wasting and fasciculation is classically seen in lower motor neuron type of lesion. Though there is nothing about fasciculation in this history, we will take wasting to be the lower motor neuron symptom, and in that case, it will be amyotrophic lateral sclerosis more than TSP. See here, see the picture here. So, in amyotrophic lateral sclerosis, you can have segmental involvement. Upper limb can be separately involved, or the thoracic and abdominal region can be separately involved, or the lower region can be separately involved. Also, these are the different presentations of ALS in the picture to the right side of your screen. And see this picture, the redness is because of UMN lesion, where there will be increased tone, increased reflex, weakness, and this LMN sign is the blue color, where you will have wasting, fasciculation, etc. in the upper limb. So, since this is possible, we'll consider this question to be a question on amyotrophic lateral sclerosis. If at all there are other two options, will be easier. As of now, we'll consider this to be the answer. I hope everyone is clear. We are not selecting tropical spastic quadriplegia or paraparesis because there is predominant wasting, which is a lower motor neuron symptom given here, and there is no other symptoms like bladder bowel involvement, sensory levels, etc., or a definitive spinal level are they in the history to favor TSP. Therefore, we consider now the answer to be amyotrophic lateral sclerosis. With that, going on to the next question. This is again a good question. This is in fact an expected question in most of the exams. See, we do not have the age, but usually this disease, what we are going to see, affects old age people. But still, there is back pain, there is anemia with hemoglobin of 9, there is hypercalcemia with serum calcium of 13, and albumin levels is 2.4, which is decreased, and total protein is 9.4, which is increased. Also, the patient has spine tenderness, and there are osteolytic lesions. We have not been given the characteristics of the osteolytic lesions. From this history, if it is an old-aged person, I would select multiple myeloma to be the best answer over bone metastasis. Why? Though these symptoms can occur in both, typical osteolytic punched out lesion or anemia, hypercalcemia, and increased serum creatinine. There are data that even increased serum creatinine has been given. You're not sure of the question. If since all these are present, and along with hypercalcemia, the Crab symptoms, we have bony lytic lesions, we have anemia, we have renal failure, and we have hypercalcemia. All this will favor multiple myeloma. But this diagnosis can be dealt with easiness if at all there are any image given out for the punched out lesions, or if there is an electrophoretic picture demonstrating the M protein spike. This would have been much easier. Since the data on the question we collected was limited, this is the possible answer that we could come up with, and we will greatly appreciate any further contributions. With this, going on to the next question. This may not be the image shown. We are not sure of the image, but such an image has been given where an arrow is pointing towards such a muscle, and it says a young patient has a sudden cardiac death. What may be the probable diagnosis? Atherosclerosis leading on to MI is a cause of sudden cardiac death in anybody, not only in young. Arrhythmia can cause sudden cardiac death like VT, VFib, etc. And HOCM, which is hypertrophic obstructive cardiomyopathy, is also a reason for sudden cardiac death, especially in young person. When we look at the diagram, normally the left ventricular muscle thickness will be more than the right ventricular muscle thickness, as you see here. But here this ratio is very much exaggerated. See the thickness of the left ventricle, it is more thicker, much more thicker than it should be. And this thickness has reduced the lumen to very narrow size. And the aortic opening is here. The aortic opening is here. Blood from here will go through this and come out into the systemic circulation. And this hypertrophied septum, which I am using the red color, this is partially obstructing the aortic outlet. So by sudden obstruction of the aortic outlet, this can cause sudden cardiac death. Not only that, this HOCM will predispose to arrhythmias, to fatal arrhythmia. These are the reasons for sudden cardiac death. If at all there is a family history of sudden death less than 40 years of age, or a known case of HOCM is there in the family who have died, these are all favorable factors to screen the patient. How will you screen the patient? Not only ECG, and ECG along with echo will do. And until these results come up, these patients should be refrained from any physical activity that may require an increased cardiac output, which is not possible in such patients. And these patients should be refrained from activity that may precipitate arrhythmia. So out of all the options given, HOCM seems the probable option. Coming on to the next question, which is a question regarding the irradiated RBCs. Now, if at all you want to give RBC from a donor to a recipient, this has gone into his system. Along with RBCs, there are possibility that other cells may also enter. These cells may exert activity on the recipient cells, or the recipient cells can attack these cells or the RBCs. These are the possibilities, few possibilities that may be happening. An irradiated RBC is the one where we use radiation to kill those nucleated cells within the blood component, especially the cellular component, and usually this irradiation will kill T cells. So these T cells are responsible for going and lodging within the bone marrow of the recipient and mounting an immune response against histone cells. So what should this be called as? I hope all of you know this. This should be called as, yes, graft versus host disease, because the graft is attacking the host. So this is graft versus host disease. Whenever you are irradiating, the T cells are destroyed. Therefore, there is no risk of graft versus host disease. Next, the RBC and also WBC both contain some antigens, but MHC class antigens are actually present only on WBC because these are nucleated. There are some conflicting reports stating that there can be hidden MHC or the HLA antigens within the RBCs, but the mainstream textbook says that RBC or a non-nucleated cell will be devoid of HLA antigens. So we take it that way. So the WBC, when this is transfused, the recipient producing antibody against the host antigens is more. When you kill them, you reduce the chance of this immunization. This immunization is known as alloimmunization because this is from one patient to the other. Now, there is an option called transfusion-related lung injury, also known as transfusion-related acute lung injury, which we simply call TRALI. This TRALI is usually regarded as antigen-antibody mediated reaction. And when this goes and settle within the pulmonary capillaries, they cause inflammation and cause pulmonary edema, which is non-cardiogenic. This is what TRALI is. So there is nothing much to deal with the T cells. This is the most accepted one, which is an antigen-antibody mediated reaction going and lodging within the pulmonary system. Now, an irradiated RBC will not decrease the probability of TRALI. So from what we have discussed, we'll see one by one the options. Transfusion-related host versus graft disease, will that be prevented by irradiated RBCs? No, it is a graft versus host disease is prevented. If the RBC is incompatible, the recipient host system is going to attack the RBC, so definitely there is risk of host versus graft disease, even if irradiated RBCs are used. Therefore, this is not the answer. This will not be prevented by irradiated RBCs. HLA alloimmunization, yes, it will very well prevent. HLA alloimmunization is a part of transfusion-related alloimmunization. That can be RBC alloimmunization, WBC, HLA alloimmunization, that will be platelet alloimmunization. Since HLA alloimmunization is prevented, we also take that transfusion-related alloimmunization is also prevented by irradiated RBCs. TRALI is not being prevented, and we will take option 2 and 4 to be the right options for this question. There is something known as leuko-reduced RBCs. Leuko-reduced RBCs is where we will not irradiate, we will use filters to filter out WBCs. But this is not 100% effective. This is not 100% effective, and some WBCs will still go into the transfusion product. So that will not prevent these alloimmunization. That can still alloimmunization is possible. So an irradiated RBC is better to prevent alloimmunization. Coming on to the next question. So you are in a primary care facility and you got to see a patient, and you now have to diagnose a patient with diabetes. So HbA1c is nothing but glycosylated hemoglobin. And these are sugar levels. One is at fasting, one is at random, the other is at postprandial. So there are specific pre-diabetic level and also diabetic level of these. So since value is not given in this one, Will HbA1c be sufficient to diagnose diabetes? Yes, it will be sufficient to diagnose diabetes. So we'll take this to be the answer. When the fasting sugar is more than 126 milligram per deciliter, this will be regarded as diabetes. When the postprandial is more than 200 milligram per deciliter, still this will be regarded as diabetes. What about random? When random is more than 200 milligram per deciliter, for diagnosis of diabetes, you should have one of classical features or clinical features of diabetes like polyuria, polydipsia, and weight loss, and so on. And if any of this is present, you can take C also to be the answer. If not, if this is the question that you have got during the exam, that I would like to go with A, B, and D, and not C, because if you have random more than 200, you should have one classical symptom that have not been included in the question. So I'll go with A, B, and D. I will go with A, B, and D. So going on to the next question. This is regarding PNH. When you study hematology for entrance exam, you would have studied about PNH. This is an acquired disorder. There is no congenital form of PNH being reported. And what is the problem? The body's own cells, few of the cells are not being protected from the complement. Complement is a body's own defense mechanism. This attacks cells that are foreign or those are infected with viral cells. This complement will act on even the body's RBC, but the RBCs will be prevented from complement mediated damage by few proteins. These proteins are defective in PNH, and these proteins are CD55 and CD59. Not only that, these proteins are anchored to the RBC membrane by GPI. These GPI proteins are the anchors for the CD59 and CD55. And this GPI is from the X chromosome and the gene is PIGA gene. The gene is PIGA gene. See here, from the X chromosome, PIGA gene will be there. This will produce GPI anchor, which will anchor CD55 and CD59 to the RBC. When these CD55 and 59 are present, the complement that comes and sits on the RBCs will be ineffective and the RBC will be going free. When there is a defective of PIGA, when there is no CD55 and 59, complement will very well come and sit, but these will be activated and this will cause membrane attack complex mediated lysis, that is hemolysis. So PNH, there is hemolysis, and this hemolysis can be different during different times of the day, and usually the patient may come with the first complaint of a dark colored urine or a bloody urine. That will be usually the first symptom, but still this can be missed, and those patients who have missed this symptom will usually come up with anemia. Because this is hemolysis, there is bone marrow activation to produce increased erythrocytes. Therefore, there will be increased reticulocytes. Therefore, the RBC size will be normal to macro because of increased reticulocytes. So, this mechanism of lysis not only happens in the RBCs, but also happen in the platelets. And this may be the reason why such patients have thrombosis. PNH patients will have thrombosis. In fact, without hepatomegaly or cirrhosis like picture, if a patient has Budd-Chiari syndrome is nothing but thrombosis of the hepatic vein. Thrombosis of the hepatic vein. This is the liver, this is the hepatic vein, and this goes in for thrombosis. Then that's called Budd-Chiari syndrome, and you should suspect PNH in such patients. So venous thrombosis is one manifestation of PNH. Not only that, these PNH patients, though there is increased cell proliferation within the bone marrow, these patients can go in for bone marrow failure. These patients can go in for bone marrow failure. A significant percentage of patients can go in for bone marrow failure. Such patients will have aplastic anemia, and such patients will have aplastic anemia. In a newly diagnosed patients, bone marrow will be hypercellular. But these patients can develop aplastic anemia. Can leukemia is a possibility? Leukemia can occur in a patient of PNH, but leukemia is not a feature of PNH. Please remember, aplastic anemia can be a feature in a significant proportion of population, but PNH is a pre-leukemic condition. Leukemia itself is not a feature of PNH. Therefore, from the options given, leukemia seems to be the exception than the other things. Hemolysis, very well. Intravascular hemolysis, good, yes. Then next, thrombosis, yes. Venous thrombosis, aplastic anemia, very well can occur. And leukemia is the odd man out of this. There is other option. I may select even leukemia, but from the given options, leukemia seems the probable answer. The question is right. I hope everyone can get this. Going on to the next question. This is again a very good question regarding acute myocarditis. There are some conflicting data from the students. Some say it is just the gold standard for diagnosis of acute myocarditis, and some say it is the non-invasive gold standard for diagnosis of acute myocarditis. If the question is so, then the answer will be completely different from each other. So, acute myocarditis is inflammation of the heart, usually because of viral, but any cause can be there. Multiple causes can be there. And acute myocarditis should be suspected if there is an acute heart failure in a previously normal person. The cardiac biomarkers can be elevated in acute myocarditis because the muscle is being involved. And for a definitive diagnosis, you must need biopsy. You must need biopsy. Not always necessary for clinical diagnosis, but for specific diagnosis, to be 100% sure, a biopsy is considered gold standard. But this is invasive. So the question is like gold standard for diagnosis of acute myocarditis, this is biopsy. Or if there is invasive gold standard investigation for diagnosis of acute myocarditis, then also it becomes biopsy. In the biopsy, endomyocardial biopsy, also called EMB, the Dallas criteria is used, which tells you whether there is accumulation of inflammatory cells plus or minus myocytolysis, whether there is lysis of cells. These are the two parameters assessed by EMB or endomyocardial biopsy. So, a definitive diagnosis of acute myocarditis requires both inflammatory cells and also myocytolysis. A possible and a probable diagnosis may not need both of them, but a definitive diagnosis should need both. So both of them require biopsy to be done. If at all the question is like non-invasive gold standard, then please remember an MR scan of the heart at acute myocarditis can pick up edema, and also there are specific signs in MRI that points towards acute myocarditis. The lesion will usually be in the mid-wall. Lesion will usually be in the mid-wall. Unlike MI. So, if it is non-invasive gold standard, then this becomes cardiac MRI. But since the question we have now is gold standard diagnosis for acute myocarditis, we'll still go with endomyocardial biopsy rather than cardiac MRI. Because there are some difficulties with cardiac MR, you cannot demonstrate a definitive acute myocarditis. But what do we do in clinical practice? Clinical practice, routinely we will not go in for endomyocardial biopsy because this is an invasive procedure. We'll go with cardiac MR only. But for MCQs, always gold standard is endomyocardial biopsy. Coming on to the next question. Here is a patient who has come up with features of chronic sinusitis and cavitated lesions in the lung. Whenever there are few symptoms, rather than attributing each symptom to separate disorder, it is wise always to get a diagnosis, to attribute all of the symptoms to a single lesion or a single disorder. So, here the patient has come up with chronic sinusitis, which is an upper respiratory tract symptom. The patient has also come up with cavitatory lesions in the lung, that is lower respiratory tract lesion. If the upper respiratory tract and lower respiratory tract are involved, we'll think of some immune-mediated injury. We'll think of vaginous granulomatosis. Now, speaking of that, coming back to the question, see here, Manto is used for tuberculosis, cavitatory lesions, tuberculosis, very much possible, but you cannot explain chronic sinusitis in such patient. Sputum culture will tell you what organism is growing, and it can tell you whether there is TB present or not, and even in a cavitatory lesion, sputum culture can be negative. This can be one of the investigation, but this will not be the next step. Bronchoalveolar lavage can also be done to see what is growing. If at all there is a cavitatory lesion because of tuberculosis and something like a fungi is growing, even this can be taken out by BAL and this can be examined. But this will not tell you the exact pathology of the or exact cause of the cavity there. Coming on to ANCA, this vaginous granulomatosis will have positivity for ANCA. Which ANCA? C ANCA. What is the triad? The patient will have upper respiratory tract infection, lower respiratory tract involvement, along with renal manifestations. We still consider the question to be incomplete. If more data comes in, we can be sure whether it is ANCA. But from the given options, ANCA is the probable answer. So going into much detail, we're going into the next question. This is a question regarding usage of antibiotics and other investigations and also about CSF. So we think that this may be a question regarding meningitis. But from the question given, please assess which of the following is true. This is a multiple type question. Should blood culture be given before antibiotics? Should CSF be taken before antibiotic? Or whether 1 ml of CSF have 95% sensitivity? Among the given options, we'll rule out one by one. So antibiotic is definitely needed if there is any infection. It can be meningitis, or it can be a systemic infection, or it can be a systemic infection leading on to meningitis. Antibiotic will work very effectively if it is bacterial. So antibiotic should be there. It will be the cornerstone of therapy. But institution of antibiotic will hamper blood culture. Therefore, blood culture should be initially taken before giving antibiotic. In fact, in the sepsis bundle that has been coming up lately, there are guidelines what to be done if a patient comes with sepsis. If a patient has come with sepsis, there should be blood culture water readily available within the emergency department. And if so, blood culture is taken first and then the antibiotic is given. But if blood culture cannot be taken, then antibiotics should not be delayed. But for the MCQs, we'll take an ideal position, and where blood culture should be taken before antibiotic institution. Therefore, first answer is right. Will that same hold good for CSF? Not for every organism, but if there are some sensitive organisms, antibiotic can affect CSF analysis for the microbe. Therefore, CSF should also be taken if you suspect meningitis in a patient who has come with symptomatology of infections before giving antibiotics. So option 2 can also be taken as right because this is multiple choice question. And regarding this third option, usually 1 ml of CSF will not be sufficient to test. It can be done, but at least 2 ml is needed for microbiological investigation. If possible, centrifugation of 5 ml will be more helpful in diagnosis. Without centrifugation, the sensitivity is as low as 30%, around 30%. And if centrifugation is done, the sensitivity increases to 70%, especially for bacteria like tuberculosis. So the option given like CSF of 1 ml will have 95% sensitivity with one-time tapping. I don't consider this to be the right option. So as of now, we'll go with 1 and 2 as the correct options. With this, we are going into the next question. Yes, Nivolumab. Nivolumab, it is a monoclonal antibody. The usage of this has been asked. This Nivolumab is an antibody against PD-1 receptor. This PD-1 receptor will have ligands like PD-1 ligand 1, PD ligand 2. Normally, the T cell will have PD-1 and the ligand for these receptors will be present on antigen presenting cells. Now, this mechanism is used by the tumor cells to evade T cell mediated lysis. T cell will lyse cells that are infected by viruses, or it causes lysis of tumor cells which has morphologically different antigens on the surface than the host cell. But the tumor cells can evade this by developing PD ligand 1 and PD ligand 2. Within the host, these are used by cells to suppress T cells, to inhibit T cell mediated lysis in otherwise normal cells, normal environment. But if there are tumor cells that produce PD ligand 1 and 2, this can come and inhibit T cell, and therefore there is increased survival of the tumor cells. And this mechanism can be blocked when any of this PD-1 ligand or PD-2 ligand or PD receptor is blocked. So that is the mechanism by which Nivolumab will act. This can be used alone or in combination with other drugs. Of the given options, it is used in Hodgkin's lymphoma. There is no concept behind that, but this is used in Hodgkin's lymphoma. Coming on to the next question. How will COVID-19 spread to the brain? Via the olfactory fibers. Olfactory fibers. How will the olfactory fibers enter the cranial cavity? This is the anterocranial fossa, and here is the nose, and here you have the fibers, nerve fibers. This will all enter this. I told you this is part of the central nervous system. This will all go into the olfactory bulb via this bone plate, the green plate, which we call cribriform plate. Cribriform plate. As soon as the COVID virus comes and attaches to this olfactory area, it ascends through the neurons, through the cribriform plate into the central nervous system. This is proposed to be the mechanism for CNS involvement early in the disease. And this entry into the cribriform plate is because of its proximity and easy connection between the central nervous system. And maybe that is why nasal vaccine or the nasal spray vaccine, which is proposed to be used in children, can be as equally or more effective than the injectable vaccines available currently. Coming to the next question. This question has stood the test of time. So this is regarding tuberculosis and HIV. These actually, the HIV incidence and the TB incidence was coming down because the period in which TB was prevalent is different from the period when HIV was prevalent. But for the last 2-3 decades, the incidence of TB is climbing up along with the peak of HIV because HIV is an infection which causes decrease in CD4 count, which decreases immunity and which increases chances of TB as an opportunistic infection in such individuals. Therefore, in the clinical setup, we see more number of patients who have both tuberculosis and also HIV. So, there are two guidelines regarding that. It is WHO criteria, which says that TB treatment is initiated first and within an 8 weeks time, ART is instituted. So ATT first followed by ART. Now, if the patient has profound immunosuppression, we mean CD4 count less than 50, the WHO says that ART can be started within 2 weeks, of ATT, but otherwise ATT should be preceded by ART by 8 weeks time, that is 2 months time. This is WHO guidelines regarding ATT and ART. So in India, we follow RNTCP, Revised National Tuberculosis Control Program, and NACO. These two has given guidelines that irrespective of CD4 count, patient should be given ART in all patients with HIV. We are not yet seeing the chronological order in which should be treated. Now, TB treatment is started, ATT is started. So we give a window period of 2 weeks. After 2 weeks, within 2 months, it can be anywhere, ART should be started. What does WHO says? WHO says give an 8-week window period between ATT and ART. RNTCP and NACO says start ATT, wait for 2 weeks, and after 2 weeks, within 2 months, you can start ART at any time. Why all the guidelines prescribe ATT to be started first rather than ART? It is because when ART is started, this ART will raise the immune levels because the affections of CD4 are decreased. Therefore, when this is raised, there is chance of IRIS. What is IRIS? Immune reconstitution inflammatory syndrome. Because of reconstitution of the immunity, lost immunity, the patients will have immune reactivity against those all opportunistic infections that they may have. The patient will become clinically worsened. The patient may have organ involvement. Therefore, ATT is started first to decrease the TB load in such patients, and then ART is started. And there is another explanation also given to that, which says a patient with TB and HIV is coming to the HIV clinic to get treated for HIV first. These patients will be spreading TB to other possible HIV patients who will be immunocompromised. These are the two reasons why ATT will be started before ART and with a period of say around 2 weeks to 2 months time. Coming on to the options above. See, ATT is started first Then 2 weeks later, ART is given. This seems a possible answer. Simultaneous administration is not advised anywhere. Irrespective of CD4 count, the NACO and the RNTCP advise ART. First initial ART is also not the treatment choice. So from the answer given, the first one seemed to be the right answer. With this explanation, going on to the next question. Diagnosis of juvenile dermatomyositis. This dermatomyositis is an immune-mediated injury where the patient will have classical features, classical dermatological features, and a specific type of weakness. The weakness will be proximal more than the distal type of weakness, and the skin rashes include Gottron sign and Gottron's papules. Papules are raised. Gottron sign or non-raised erythematous rash over the extensor surfaces. See here, these are very much raised, and these are reddish erythematous but not very much raised. These are Gottron sign and Gottron papules. See the exposed area, this region is erythematous, and this is called V sign and also shawl sign, because this is the region, this looks like where a shawl is being applied. So these are known as V sign, where in the anterior neck and the chest we have erythema, and a shawl sign where the back of the neck and shoulders we have erythema. Apart from that, the patient may have telangiectasia, that is dilatation of the capillaries in the nail bed, and also subcutaneous calcium deposition is also possible. For a diagnosis of dermatomyositis, the diagnosis of which requires classical DM rash or dermatomyositis rash, after the given options, we have Gottron's papule normally seen. Mala rash and the photosensitive rash are usually features of SLE. Going on to the next question. Next question, it is regarding COVID discharge advice. So a patient is getting discharged from under your care, and now the patient needs to be advised. So what are the advice you do? So especially there is a risk of complications arising out of our therapy or arising out of COVID itself. So you should advise the patient to be isolated for some time, to be isolated from others for a period of 2 to 3 weeks time. The patient should be advised to visit the hospital if you have stroke or MI-like symptom or features like sinusitis. Why? Because there is increased mucormycosis risk. Or if the patient has hip pain, why? Because there is risk of AVN because of excessive steroid use by some. So when we look at this, if there is head pain or facial pain, this can be because of sinusitis. So an prompt office visit is necessary. Take RT-PCR after 7 days of discharge. You'll wait. Sinusitis-like symptom, yes, this is again a possibility. For mucormycosis, the patient will be advised to review. But regarding the option B, this is the Government of India policy regarding treatment of COVID-19, which says no RT-PCR test needed even before discharge. In that case, why should the patient be advised to do an RT-PCR 1 week after discharge? This is wrong, and this is not an advice given to a patient. So after discharge, The patient will be asked to take care of himself for a 7-day period, not an RT-PCR. So, from the given options, if it is a multiple choice question, I would like to go with A and C. Coming on to the next question, it is regarding topiramate. What is topiramate? The use of which is asked here. Topiramate is an anticonvulsant. Topiramate is an anticonvulsant. What is its mechanism of action? Mechanism of action, it acts on multiple levels. I use the name mnemonic GluNAC. It acts on the glutamate neurotransmitter, glutamate receptors. It acts on the sodium channels. It acts on the potassium channels. What does it do to them? The glutamate receptor, it blocks the glutamate receptor. It blocks the sodium channels because glutamate and sodium are responsible for depolarization of the neurons, and it blocks sodium and glutamate receptor. Opposite to that, it opens up potassium. It opens up potassium channels. So these are the mechanism of action of topiramate, which is not asked yet. What is the question here? What are the uses of topiramate? Now, the topiramate is used for GTCS, not the first line, but it is used in GTCS, myoclonic seizures or partial seizures also. Is used in LGS. LGS is Lennox-Gastaut syndrome. This Lennox-Gastaut syndrome usually occur in children, and there will be seizures plus mental retardation. Even in here, topiramate is not the drug of choice. It is being used, but this is not the drug of choice. It is also used in bipolar disorder. It is used in bipolar disorder. Where else it is used? It is used in many other conditions like prophylaxis of migraine. It is used in prophylaxis of migraine. It is used as a newer drug, or new use of topiramate is in alcohol dependence. Alcohol dependence. These are the uses of topiramate apart from its use in idiopathic intracranial hypertension also. So these are the uses of topiramate. Here, what are the options available? The options available include LGS, which is Lennox-Gastaut syndrome, and treatment of migraine. When you note carefully, this is not used in the migraine treatment, but this is used for migraine prophylaxis. Migraine prophylaxis. There are many drugs used in migraine prophylaxis. The commonly used is the beta blocker, which is propranolol. But there are many other drugs used in prophylaxis of migraine. One such drug is topiramate, and therefore the answer here is LGS, which is Lennox-Gastaut syndrome from the available options. I hope everybody can get this. Coming on to the next question. This question is another interesting question. It is regarding CVA. It is stroke. After an acute stroke, a patient has come to you within 2-hour period. His or her BP is 160 over 100, blood glucose is 160 milligram per deciliter, and your junior or somebody advised NC-CT, which is non-contrast CT, and this non-contrast CT is normal. What is the next best line of treatment? Next best line of treatment. Normally, non-contrast CT is done to rule out hemorrhage. To rule out hemorrhage, because a hemorrhage will be appearing whitish, or it will appear more dense. So, a hyperdense lesion in a patient with stroke tells you that it is a hemorrhage most often. There are other reasons for hyperdense lesion, but still in an acute serious setting, this tell you that it is hemorrhage. If that is not present, then it might be infarct also. It might be infarct also. So, when NC-CT is normal, we will consider that to be infarct, and we will proceed with the treatment after the NHSS scoring. We will proceed to thrombolysis. If he is within 3.5 hours, we will proceed with thrombolysis, which reverts the pathology in CV. At least we will save the tissue that has not gone in for infarction. But that is not the option given. Ideally, when we speak, non-contrast CT should be combined with CT angiogram. In a well set up hospital, both of this has to be finished within 15 minutes time period after patient's arrival to the hospital. For a soft tissue, MRI is definitely better, but MRI will take time, and for each minute delay in specific treatment to stroke, you are losing around 1.8 million neurons. Imagine 1.8 million neurons, almost 18 lakhs neurons is lost for every minute delay in treatment. Therefore, NCCT, which takes less time, is usually done over MRI. MRI at a later date will tell you definitely where is the area of infarction. But ideally speaking, in a well set up institution, NCCT should combine with CTA. Why should CTA be combined? In such patients, when NCCT is normal, what are the possibilities? The NCCT normal may tell you whether the infarction has yet to appear on CT. This is one possibility. The second possibility is there can be a subarachnoid hemorrhage, which cause narrowing of the vessels leading on to stroke symptoms. And this SAH will usually be seen, because this is again a hemorrhage, this will usually be seen in non-contrast CT, but 10% of SAH may not be seen in non-contrast CT. And also to know the location of occlusion, where is the occlusion, we use CTA. So the CTA will tell you where is the occlusion, if at all there is an occlusion, and if at all there is an LAH, it will tell you the presence of SAH. So this is the reason why non-contrast CT is combined with CTA, and if it can be done within a 15-minute window, usually both of them are combined. Therefore, in the previous question from the available options, this is a possible answer. What about MRI? MRI will definitely take time. So if you have suspicion of TIA, you may subject the patient for MRI. But this usually TIA patients will start resolution of symptom within 1 hour period after symptoms. That is not the case here. So MRI is out of the option. Regarding antihypertensive therapy, you may see that the BP is little on the higher side for this patient. Now comes the concept of ischemic penumbra. If this artery is supplying this area, this artery will also give tweaks to the other areas, and the other area will receive similar tweaks and similar artery supply also. When this artery is occluded, this area that is receiving supply absolutely from this artery will undergo necrosis or death. The cell have died. This area cannot be reverted back. No reversal. This is irreversible cell death. Whereas these areas will undergo ischemia, and the symptom is developing because of this. These symptoms will tell you that the patient is evolving. The stroke is evolving, and these area can be salvaged. These are reversible ischemia, reversible cell injury. So the purpose of reperfusion is to salvage all these areas. And this increase in BP can be because of body's response to salvage these areas. So until the BP is more than 220/110, hypertension should not be treated, or the raised BP should not be treated. Only when you are planning for thrombolysis, the systolic should be brought less than 185. Otherwise, unless the BP is more than 220/110, it need not be treated. Therefore, in this patient who have BP of 160/100, even if you plan thrombolysis, the BP need not be brought down further. Therefore, this is not the immediate next step. From the options available, now we have non-contrast, contrast CT or CT angiography. So from the options, this is the next possible answer. So this concludes our session and an immediate recall of INI-CET questions in the medicine. We will come up with a detailed answer and a full questions the sooner. I thank every one of the listeners, and I also thank ADrPlexus for the opportunity. Thank you, everyone.